Hello everybody, we are live. Going to be starting class momentarily. In the meantime, what you are looking at here is the Pain-Free Mobile, traveling around Chicago to locations, broadcasting our new show, Woman vs. Pain. It's a reality TV show that's going to be Sharon going to places, everyday places, places of work, places of recreation, places of education, and working on people who had no idea that there would be a solution to pain that was simple and easy and they could do for themselves. So those of us in the bodywork field, we know that the major thing we have to combat in the field is awareness of our abilities to help people. People are not aware that pain can be solved by all this great hands-on work that we do. So they think pain, physical therapy. They think pain, cortisone shot. They think pain, Vicodin or Norco. They think pain, surgery, or just arthritis, aspirin, Tylenol. How often do they think trigger point therapy? It's just not the first thing that pops into most people's minds. So we've long known this, and so we are determined to bring huge, massive awareness by a live reality TV show where Sharon goes out to the world and proves that pain can be beaten with simple hands-on techniques that everyone can do. So this is our van. It's actually the best Euro van you can buy. It's better than the Mercedes. It's the top-rated one. It's actually made by Ford now, and we've got actually a little bit better rims on. We've got fancy rims on ours. But other than that, this is what it looks like. And ours might be a little... No, I think that's the right size. So this sign is 147 inches long. It's 12 feet, a little over 12 feet long, and it's quite visible. In fact, I can give you a shot of what that looks like. Oh, here we are, beautiful night in Chicago. Still not getting used to the weather yet, but let's take a look at what we've got here. There you go. All right. There it is. Oh my gosh, and here she is. Not only is she the star of the show, Woman vs. Pain, which this banner is right across, so you can see how big it is. I'm not joking. It is literally huge. Over 12 feet long on the side of this big, enormous 9-foot tall van. But we're also showcasing our new upcoming product, Sexy Not Painful. It's not a sock. It's not a slipper. It's not hosiery. It's slips. And they're sexy, not painful. Why are they sexy but not painful? Because you can wear them with the hottest and latest, greatest shoes, but they correct the #1 cause of myofascial pain, Morton's foot.
Great.
All right, will you show us what's so special about your socks, Miss Sexy?
Well, I'm just going to show you that here we've got shoes. Now, some people, like when I went to Hawaii, they didn't wear shoes a lot of the time. So I was trying to figure out, well, what could we do? So what happened is after a treatment, they'd order a set of 100 of these, and then we'd start putting them in all their shoes, and you can attach them to your feet. But another thing, how about if you're going to go to the store and buy a new pair of shoes? Well, if you have them attached to your socks like this, you can take them your shoes out of your and try a new pair of shoes on, and you'll have your first metatarsal lift right on your sock.
So you're saying if there was a light and comfortable slip that you could just slip on your sock with a nice form fitting for the heel, and it had the right amount of support underneath the metatarsal head, then we could correct metatarsal lift deficit problems wearing something comfortable.
Right, and so this is another pair of shoes. These often cause you to flatten your arch.
Oh yeah.
And have hyperpronation, but with your first metatarsal lift on your sock, there you go. You're correcting it right there.
Absolutely.
So this is correcting it. And here another one, so you can go right into your, and then you can, you're gonna go, maybe you're working downtown, you're wearing your high heels, and you go right into your gym shoes to walk to the train.
Yeah, exactly. Right?
Now, some people, they needed 6 millimeter lift. This is 3, and the thing is, maybe I had 3 millimeters in their shoe. So you might have 3 millimeters in the shoe on a regular shoe. So first metatarsal lift there, maybe 3 on their foot, and then they have 6 when they put their shoes on.
Right.
So, and then when they take their shoes off, they still at least have the proprioception of the lifting of the first metatarsal at least 3 millimeters. Yeah.
So by now, all of you should know that this is a huge part of what we do to help people out, because it is almost ubiquitous congenital deformity where the first metatarsal does not to grow fully, and it shortens up a little bit and is up and back from where it should be normally positioned. And in order to get the body to push off on that first toe, it has to jump over the second toe, causing that inner falling of the foot. The ankles roll in, the hyperpronation, the formation of bunions, all those nasty calluses that form on the toe and the side of the big toe. And this little lift prevents all that by bringing the ground up so that the toe doesn't have to go as far, drop in as far to hit it. And so now...
So Justin, take a look at my feet. Now remember, I used to have a huge bunion. The bunion used to stick way out here, and my great toe used to come over to here. Yeah. And so I used to wear a lot of high heels before I was 30. And and then what happened is I had a first metatarsal deficit. And to get my big toe onto the ground, I was turning my feet out like that, and all my toes were getting like that, and then the knees were going in.
Absolutely.
So I corrected that by putting a lift under the first toe.
Show me the knees again.
Oh, often the knees go like this. Yeah. So you get like this, and then the knees come like that. So when you take, and then children, a lot of times of people that have this problem, end up having this problem when they're really young. Oh, say, for instance, the young is 3 or 4, 5, 6-year-old. They're trying to play soccer, and they're walking, and they're putting all their weight like on their talus, and like that. So
causes all kinds of problems. And then the reason it's so pertinent for today's class, because we're talking about all the muscles on the lateral side. So show us what someone might do if that was happening and they wanted to compensate.
Then they'd really be tightening these muscles a lot.
They'd be yanking,
and they'd be overstretching this area right here. So they'll be overstretching, and they're growing, and then they'll be growing bone right here.
They'd be forcing the muscles on the sides to contract, to yank the ankles back up, causing just tension that radiates all the way up.
Well, they're shortening here.
All the way up.
Yeah. So a lot of times what that you do is when you have this happening, then you usually you bend at the hips, your head goes forward, and usually one shoulder goes down and one hip goes up.
Yep.
So what you want to do is measure that and look, oh, if I put a lift under, does it make the shoulders even? And does it make the hips even? Does it stop you from having your knees falling in and your ankles falling in? And does it feel good?
And oftentimes it does, just one little lift like this. However, this is the best product we have for it so far. It goes inside your shoe, but then, you oftentimes have to get multiple pairs for multiple shoes. And it doesn't help when you're walking barefoot, and it doesn't help when you're walking in some flip-flops, because these don't work well in flip-flops. I mean, they can, but not so well. It doesn't work well when you're doing a lot of other activities, but if you had them as part of your sock, so Shark Tank, here we come. We are building this new product called Slips, which has the lift sewn right into a very comfortable, sexy sock that will be really attractive looking, because women won't wear unattractive footwear.
Yeah, you should imagine this is a really nice, a really fancy sock.
And it'll have metatarsal lifts of 3.5, 6, and 9 millimeters.
So what if I want to be barefoot? Then I take off my shoes and I still have them on my socks.
Exactly.
And of course we could walk on our pebble mat while we're working. And also this helps to have, like, if you end up having a lot of peroneus dysfunction here, if you're not used to, if you're, say for instance, you're going to Hawaii, okay, and everything in Hawaii is uneven, and everything in Chicago is flat as a pancake, especially down here. These condos, there's no steps anywhere. Okay, so, and in Hawaii, so this is good to do before you go to places like Florida and Hawaii, where there's a lot of movement. So you're trying to get this movement of your ankle in, this movement of your ankle in. You're looking to get that. You're also looking to do some knee bends. And here I've got my first metatarsal also corrected at the same time.
We'll be covering more about that at the end. We're going to go over the first metatarsal lift again. But remember, it's the difference of having an ice skate under your foot where the weight is distributed between your heel and your second toe. Here, why don't you hand me that brochure?
So here, this is, yeah, but also you could look at here. So it's like
a pencil. It's like either stepping on,
and then you're like rocking like this.
Show me the pencil again.
Yeah.
There it is, the pencil. It's like stepping on top of that pencil.
And the middle toe.
And having all day to wobble back and forth, causing muscles to fire all day long, keeping you straight. Or, and there's a picture of that, I believe.
And here it makes, this is like a tripod.
And this is like a tripod. When you put that weight under here, then she's got equal amounts of weight here, here, and at the heel.
Yeah.
She's got
and you're
a tripod like this,
mm-hmm.
instead of like this.
And you're looking for the knees to track over the great toe or the, and not, so you know you need a 3 millimeter if your knees come in like this, but you might need a 6 millimeter if when you go like this, your knees come in like that.
The difference in feeling that someone will notice when they become conscious of the difference is when they've got this that they've been walking on, this they've been walking on this ice skate where it's been wobbly. When they put that extra support under the metatarsal lift so that it's a 3-prong, suddenly their shoulders will relax, they'll stabilize, they won't feel wobbly. You know, some people when they stand, you can actually see them drift a little bit, especially if they close their eyes. They're drifting because their body's constantly trying to find balance. Then you put that other thing there, and then they're just stable. Their back relaxes, shoulders relax, neck relaxes, ankle and calf muscles relax, and so that's...
Now that I'm older, I think if I don't put the first metatarsal lift in, then I really can't wear high heels anymore. Yeah. But if I do put it in...
I find the same thing for myself. High heels are just out of the question unless I've got my metatarsal lift.
We're going to get you some dust.
Not without my slips. Just won't do it. Not going to happen.
Halloween is coming.
And you always want to get your range of motion in. So whenever you get a chance, you go like this, and you're going to
maybe not with your $300 pair of shoes, but maybe.
These were not $300 pairs of shoes.
We're not recommending $300 pair of shoes.
Well, I don't think I've ever bought a $300 pair of shoes, but I'll look forward to it in the future.
Yeah. Your birthday's coming, we'll get you some.
Look at that.
You're going to go stretch your gastrocnemius. And then come down, and then you can do your soaks.
Yeah.
So those are some of the nice stretches that we should do. Also, for our gluteus minimus, we're going to walk with our toes in, and our toes in, out, and toes in, and toes out. And then we could also do the grapevine. That would stretch our gluteus minimus. And vastus lateralis, we could give it a nice stretch like this and take it back towards the other side.
There you go.
Yeah.
Good.
So those are some of our nice tests. Okay, so it's so easy to go if you have it attached. If you have your lift right on your slips, then you can go from pair of shoes to pair of shoes and your slippers.
That's right. You can go from any kind of shoe to another shoe, and you can wear the best looking shoes according to modern culture and not cause serious trigger point and myofascial dysfunction in your body.
I can wear these actually. I can dance in them.
Yeah.
And wear them, you know.
Yeah.
So it's not.
In fact, to tell you the truth, if you bought a great pair of shoes but you didn't pay attention to the metatarsal lift,
I couldn't wear it.
Yeah. You'd be better off in high heels with the metatarsal lift, maybe, than you would in actually consider,
and stuff that don't have the first metatarsal lift. Yeah.
So everybody says high heels are so bad, but the truth is, first metatarsal lift is what is the biggest problem to avoid. So we could get socks. Well, not socks, slips. That could solve the whole thing. Like I said, Shark Tank, here we come.
Yes, that's it. Okay, so our first muscle we're gonna look at today. Let's take a look at it.
Well, what pain key region is it?
Oh, today is 29. The lateral leg, right here. The lateral leg.
And we noticed something. 29 and 32.
And 32
have such similar muscles. We thought we could just do both of them.
We added 32, so all of you, they're gonna have to put the 32 into, and that's lateral ankle pain.
Lateral ankle pain.
So it's 29 and 32. Okay.
All right. Do we
so
have
today,
that chart here for us?
Let's take a look at that. Yeah.
By now, everybody has printed this out, I am sure. And we go down to the ankle.
I have to put my glasses on.
29 and 32. There it is. 29, 32.
Mm-hmm.
So here we are. 32 is lateral ankle pain. The peronei muscles, those are the muscles on the outside of the thigh, outside of the calf, sorry. Those
And the
guys right
gluteus
there.
minimus. The third most likely is the gluteus minimus.
gluteus
And
minimus.
29's on the other side.
Ah, 29's
It's
on the
somewhere
other
somewhere
side.
around here.
There it is.
Okay.
Lateral leg pain.
Lateral leg pain. The most likely one is gastrocnemius.
Right.
Second most likely is gluteus minimus. Then the peroneals. And then the vastus lateralis.
All right. How about we take one muscle at a time? Let's rock these things.
Let's do it.
Let's do it.
Let's do one muscle at a time.
Let's see. One muscle, we need to know what its referred pain looks
Yes,
like. We
we'll
need to
look at
know
that.
its origin and attachment and
That's
where it
right,
is. We
that's
need to know
right.
its anatomy.
Right?
We need to know what nerve supplies it,
Yes.
so that we can work on the supersensitive spinal segments,
Right.
all the little tiny muscles that control the nerve opening
Yeah.
to that muscle. And then what else do we need to know? Oh, range of motion tests.
Yes, range of motion tests
Yeah.
and maybe some strength tests.
Yeah,
and,
true. Strength
And
tests.
also, we might note some nerves that get compressed by the muscles.
Right. Any special extra problems that certain
The
muscles cause?
peroneal nerve this time.
Well, that one causes peroneal nerve
Well,
entrapment.
the peroneal muscle can entrap the peroneal nerve, causing what dysfunction? Can anyone think of a dysfunction?
Drop foot.
That's it. Drop
That's the one.
foot. Drop foot.
You're walking and you just can't get your foot
Yeah,
to
you can't.
pull
So
up,
this
and
is
it
drop
just
foot. So
just-
you're walking and ooh. You
Yeah.
can't, ooh like that.
or doesn't. Well, oh no, it's and there's that's not to be confused with slap foot, right? Slap foot is the anterior
Yes.
tibialis. So
no, anterior tibialis is drop foot.
is drop foot also?
Yeah. But the nerve to anterior tibialis is the peroneal
right.
nerve.
Okay, all right.
And so when it goes, so if it gets compressed by the peroneal, what if you have first metatarsal deficit, you don't correct it, you could have really tight peroneal nerves, that could compress the peroneal nerves and then cause you to have drop foot.
Aha. Is that the same thing as slap foot then? Like when they
yes, it
step
could
and it
be.
goes slap. You hear someone
Yeah.
walking, it goes ka-slap, ka-slap. Is that the same kind of thing?
No, drop foot means that you can't lift it.
Yeah. So you're
So-
more like stumbling over it. And
Yeah,
stuff
you
like
can't.
that.
You mean to lift it, but you can't lift it. So then you drag your
Ah,
foot like
gotcha.
that.
Yeah.
So go like that. Okay.
All right.
So that's a couple of things we're working on.
Fantastic.
Okay. So.
And Sharon just went to a conference last weekend.
Oh, I did.
Did you have anything fantastic to tell us about it? Or
Well,
anything?
it was a lot. You know what was great?
Well, people came up to you and said that they saw your show. So
They did. So people that were watching the show came to the National Association of Trigger Point
Great,
Therapists
great.
convention, and they were like really we
excited that you were there.
They knew everything.
They knew the range of motion dances and
They
stuff.
did. They knew everything. They
That's
were really
great.
excited, and so it was fun meeting them.
Yeah.
Yeah. Oh, well, I could do a little shout out to some of them.
All right, here we go.
Here's the so I'll put here's the NEMT-PT, and here's some of the people. So here's one of the people that have been watching the show, Marcia Klaus.
Marcia Klaus, hey.
Hi, Marsha.
And some people that were there, are the Myo Buddy people were there. So
My
that was
buddy,
great.
that's that buffer that we've got.
Yeah. Renee Hart. Shout out to Renee Hart.
Renee Hart, yes.
Yeah,
thank you,
yeah.
Dr.
Deborah
Renee.
Moran up in New York,
Right.
in the city, and in Wisconsin, Carla Hedke, and we saw a physical therapist there from Alaska, Denise Jerome,
Nice.
and Tasso Spanos was there.
Still going strong, Tesla.
Yeah, he was.
One of the old originals.
He's doing it one of the greatest, and,
Yeah.
and he's working in Columbus nowadays.
Nice.
And Rosemary Quander from the Pittsburgh area. So those are a few of the people that we saw there.
And
Steph and
Renee
Daisy.
Gladio from Pressure Positive.
She was there.
Yeah.
Renee. Oh yeah, there was a lot of people. There's lot more people than I said. There's a lot
All right.
more people, but
Wonderful. Well, there's a few of them. All right,
And
great.
Dr. Gerwin got a wonderful everyone appreciated his lecture, and he got an award. It was a great award. Yeah.
Oh yeah, he did a great job. Someone said that that some of those numbers didn't print out on their chart. They should be, but it's if not, look here. It's just 29 is at the lateral side of the lower leg. That's the leg, and this is the thigh, folks. Officially, that's the leg and that's the thigh. But anyway, that's the lateral lower leg, okay, and the lateral ankle is 32, so 29, 32. Okay, pain in the lower lateral leg and the lateral ankle. All
So
right.
we have a few guests here today.
And we have some guests. Great.
Okay, go ahead and stand up. We were heating up some of their muscles here. So tell us who you are.
We're cooking them up a little bit. Oh, the list of muscles should be there. I don't know why yours didn't print it. They really are there, I swear. I'll check again though.
So go ahead, tell us who you are and how long did it take you to get here?
It didn't take me long. I live like 10 minutes away.
Awesome.
My name is Nora Winsberg, and I'm happy to be here.
Wonderful. And she wished she'd been here for the knee one.
Yes.
That's all right. You might fix your knees.
I need this one too.
Hey, this one can fix a lot of knees.
Lateral leg and lateral ankle today.
Yeah, and that might fix your knee. You never know.
Hi, and I'm Camille Matuszewski from Massage as a Ministry, and I've known Sharon over 30 years, and I'm here every week.
Yeah, she is with us. She's one of the troopers. Stephanie's hiding back here somewhere.
Stephanie.
Hey, Steph, the wizard behind the curtain. She's the one who gets it all going. All right.
Okay, great. So we're
And
going to
here's
take...
your
I'm
teacher
taking
for the
shoes.
evening, Sharon Sauer.
Yes,
She's
hi.
putting her favorite shoes on because
Yeah,
she doesn't
yeah.
want to wear heels all the time.
Well, no.
I don't.
Okay, so let's take a look at the gastrocnemius muscle.
So this
So-
is the most likely muscle. This is the top one on the chart.
Yes, to call lateral leg pain. And you can see that the trigger points high up here will cause some pretty good pain on the lateral leg right here.
So what you're
And
saying
also
is
here.
the
So
lateral trigger point kind of up where it attaches by the knee and the fibular
Right
head.
there.
Yep, that's what
This
causes.
is the one that causes lateral leg pain there.
Gotcha.
And this muscle attaches right here. It crosses two joints. It crosses the knee joint and
That's
the
right.
ankle.
That's right.
And it attaches right here on the lateral condyle of the femur, and then attaches down here by the tendon of the Achilles tendon to the posterior surface of the calcaneus. So that's our muscle, and of course, it's also the other head also causes plantar fasciitis, which we're going to get to later on.
So
See?
if you got your trigger points on the medial side, the
Right.
other side, you get that plantar fasciitis.
That's
pain.
right, that's right.
And then on the outer heads, then you'll get lateral leg pain.
Lateral leg pain, and so that's the muscle right there. So let's go ahead and do a little evaluation of that muscle.
Sure. What nerves feed that?
It's S1 and S2.
S1, S2. So
Yeah.
way down there. So
Yeah,
you
so
would,
take a look
you
at
would
where
do
S1
skin rolling
Right
way
here.
down over the sacrum.
So here would be like, here's L5, so S1 and S2. So we do skin rolling right there to see if those nerves are working.
Yeah.
And see if they're having heightened tone that would cause you to have trouble with the
That's right.
gastrocnemius.
And if the skin is tight and pulling and not lifting easily, then we would work on all the rotatory muscles and the, rectus
multivities,
spinous, all that
and
stuff.
correct.
All right.
Let's see if those might be causing. Also, we have four tests that would do 35, 36, 37, and 38.
Yep.
So we're
let's
going to
see
do
what
those.
are.
Go ahead.
Easy tests this week, not hard ones. So 35. This is the knee lock back test. That's pretty simple. Then it's, of course, the gastrocs are involved in the standing toe touch. They are involved a little bit in the leg lift here, which is similar. Although we usually evaluate hamstrings, of course, the gastrocs are involved in that leg flexion like that. And then 37, this is the one
Straight
that we're
leg.
going to use the most. We're going to use this one the most.
That's our main one for
Main one for the gastrocs.
the gastrocnemius. There, it's all in red. There, you see.
Okay, that's
So,
why it's exactly.
Right there. Okay, so that you could have a person lay down and have them spread the legs straight, and then you're going to see if they could get at least 15 degrees or 15 to 20 degrees of dorsiflexion.
Why is the knee straight but not bent?
Because then that muscle crosses two joints.
Right, so if you bent the knee, then you'd be relieving the
Upper
knee.
portion.
And so then you'd be only testing the soleus.
That's right.
The soleus, which doesn't cross the knee. So
Okay.
you have to have the knees straight if you're going to test the gastroc, and knee bent if you're going to test the soleus. All right?
Yeah. So let's go ahead and
Sweet.
let's do some of these nice tests.
Okay.
So I'm going to move a few things off of my table here.
And whose gastroc are we testing?
Well, let's see who will test. Let's see.
Anybody want to volunteer as a gastroc model?
I'll volunteer.
Good. Okay, I'll lower the table for you. Okay.
call that low. For your height, it might be low.
You can tell it's it's class day when Sharon's all her materials are out. Everything that she knows about the subject is now covering all of the shelves.
Okay, so we want your feet off the end of the table. Good. Okay, so here we'd like to take a look at the dorsiflexion. So we could take a look here. So you want to bring it to neutral first, so you can go to 90 degrees with your goniometer if you want to. I'll do it on this side here.
Okay, sure.
So you put it right here, just this right there. You're going to put that right. So this is right in the line with the bottom of the foot.
There you go.
And then you want to see if you can get 15 degrees of flexion. To 20, 15 to 20. And no, we're not getting. No, we're not getting very much flexion. So if we go to 90, that's about what she wants. She doesn't really get any more flexion.
And what else? End feel. Especially in a joint like this, end feels are important. So, what it should feel is it should smoothly go to the end, and then it should just have a soft lock at the end.
Yeah, so this is just about 90.
It should give you resistance along the way.
So we should get it to go to about to here.
Yeah, and then it should be soft.
Yeah,
and
like
stop. If it's fighting more and more, then like in a rubber band, then you know that you've got myofascial shortening.
So we should be able to get it to go a little easier to there.
Yeah.
Okay.
Okay.
Okay. So let's take a look at the other side.
All right.
Okay, we'll put it first to 90. So you put it right here. Put it right on the bottom of the foot. I'll do it on this side so you can see me.
Yep, sounds good.
So you're just trying to get to 9. So you put it 90, and then from there you try to. There, this one is going, yeah. So this one has, let me check it. It's got about 10 degrees over here. So 10 degrees here and maybe 5 degrees here. So we want to improve that, yeah.
Yep. Good. How about strength tests? I could show you a quick strength test if you'd like.
Wonderful. Okay, that'd be great. Let me take a picture of you while you're doing that.
Okay, so for the strength test, because it crosses both joints, you bring the knee up the knee bent 30 degrees and the toes flexed like this. Okay. If you wanted outer gastroc, you would turn it in like this. If you
we want inner this time.
Like that. So keep the toe turned that way.
And point it slightly.
Okay. And then I keep my elbow straight because I have too much wiggliness here. I keep my elbow straight. And I say push up into my hand. Push up. And then I add 1, 2, 3. Now. And then by 2 or 3 it's weak. So if we were to do inner, then we would turn it in. And I would push like this. 1, push in. Then I add 1, 2, 3, and that one actually is stronger. So the lateral one is especially weak.
Yeah. So it might be good to treat
point the toe. So remember, 30 degrees, toes all the way bent, turn out, push up in my hand. 1, 2, even 2. And when they want to move their foot out of position, what's that called? Recruitment. They're trying to recruit other muscles to fight it because it inherently already feels that it can't do it. So it's now bending and doing. It's like when you're testing a neck muscle and someone starts pulling their shoulder into the mix, or something like that. Okay? Or you're testing a wrist muscle and someone starts bending into the biceps.
Thanks for inviting your followers. Wonderful.
Oh yeah, do that. Okay? Test the other side real quick.
Sure.
Okay? So again, bend to 30 degrees, toe flexed all the way, then turn outward and push up into my hand. Push up, and I add 1, 2, no, nothing. Okay?
The lateral, nothing.
Yeah. And then let's try the same thing. Toe turned in. Push up into my hand. 1, 2, 3. And again, strong. On the medials, gastrocs were strong both times, and lateral was weak both times.
Okay. So we had a little bit of...
Already you should be going ding, 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 ding. First metatarsal. You should be thinking about it. Okay? All right, back to Sharon.
Okay. And... so let's take a look at the nerve roots, okay? So we're going to take a look, and let's pull this down just a little bit. So this is nerve roots while she's laying down.
Okay.
And so we're looking at S1 and S2. So here we're looking for the skin to roll. And you see as we're coming here into the L's, it's not rolling as easy, sort of it's hard to pick up. And also, okay, so the S's are pretty good right here.
Yeah.
Okay, but the L's are pretty tight.
That's good. Yeah.
The lumbar. So
you guys know the trick for finding L4, right? So the top of the iliac crest right in the middle, that's L4. See, top of the iliac crest right in the middle, that's
then
L4.
Then that's our L5.
So then L5 is the one divot below that, and then your sacrum right down there. So
it's rolling here, but it's not rolling at L5, L4, L3, L2, It starts to start rolling again at L2.
Yeah.
So
Okay.
so we could go ahead and do just a little bit of the treatment there and see if we might see some improvements
Okay.
by doing
Yeah.
it. So we'll try and see if the rotatories or the multifides or some of the other paraspinals might be causing some of the heightened tone or some of the a slight compression of the L4, L5, S1.
And we'll have crossovers to the other muscles. Remember, everything in the lower limb is fed by the lumbar spine and sacrospine roots, nerve roots. All the upper body, upper limb muscles, they're fed by the neck, and a little tiny bit from the upper thoracic, but mostly the neck. So,
So this is just looking at it laying down.
Yep.
You might want to look at it seated or standing as well.
That's
so,
right.
So everything, but for sure, looking at it this way is telling us at least how it is when she's laying down.
exactly.
So I'm right on the S1 and S2.
And if you treat it and you see good change, and then the patient goes and comes back, and it's returned, then you say, well, what caused it to come back? You must look for underlying perpetuating factors, and you must make sure that you evaluated every factor affecting that muscle. So that's it's perfectly all right. Plus, there's just a natural time that it takes for the muscle to retrain itself, too. That's why we do self-care.
True.
Yeah, the self-care is really important, not just because, of course, it's working the muscle, but it's reminding the muscle. Self-care is reminding the muscle of the treatment it had last visit and why it's supposed to be and what it's supposed to be doing.
So I was just going. So I'm treating that area on her, right?
Yeah.
But let's have you treat it too. Well, so to treat the L4, L5, S1, S2. So while we're treating, so why don't you go ahead and use this ball, and you can do that on the wall.
Oh, okay.
And let's have you come over here, and while I'm doing the other side over here, I'm going to check you. Come over here, right here, and I'm going to just check you for a second. Standing this time. Okay. So here, we're going to see. Can we lift up the tissue here? And it's lifting up pretty good. Oh, but when we get to L5, about L5 and S1, it's not. Okay. So here's okay. The thoracic, the lumbar. But here at L5, it's a little tight.
Okay.
So once you go ahead and put your ball right here and here, turn around it put it on the wall, and then you're going to come here and you're going to look around for painful tight spots there and below there on your sacrum. Okay, and you can imagine, you can see where I am on her.
Good, good, good. And you can sometimes flex a little forward too to get a little more spot. Yep, good. Anything that feels like you're getting into the muscle is good. It's okay to creatively, move around to get the best pressure at the best angle.
So here I'm looking for some taut bands in the rotatories and multifides. So I can feel the spine here and the transverse processes. Going towards the spine, pressing straight in towards the vertebrae and towards the transverse processes. I'm going to go a little inferior, so feel the spine come just lateral to it. And I'm looking for some taut bands in there and some painful spots. I don't see anything right there, so I'm going to I feel the spine come down a little bit lower. I feel a little taut band there. What do you think,
Oh, they're all tight.
Camille? Okay.
Everything is tight, but it feels wonderful.
And you would spend as long as you need to on that. There's a lot more that could be done. She
So
could
what
be
you could
bending
do-
over the table. She could have her arm tucked under to give
Yep,
a
it could
rotation.
give a nice rotation.
Yeah, there's a lot.
So the
that can be
idea
done.
would be that you keep treating it over time or today even.
Yes.
Until you get it to really roll good, But how about if it's just slightly improved? That's still really great. That
Yeah.
means you took away some of the underlying perpetuating factors in the gastrocnemius heightened
Exactly.
tone
Exactly.
and trigger point development.
And what if you put a first metatarsal lift and gradually that area softened up all on its own?
It may.
Just have someone stand and do the skin roll,
Okay.
then put the first metatarsal lift and a few minutes check later and do the skin roll again, and you might find
Okay, so
a
the
softening.
skin rolling is better. Okay.
Okay,
So it's
good.
better. So I'm going to go on to take a look at the gastrocnemius. Okay.
Great.
Okay.
How would you
So-
treat the gastrocnemius
Well.
as a master body worker?
Okay, we'll take a look.
I have a feeling something about on the stretch is going to come.
Yeah, but it's going to come. So remember the lateral gastrocnemius head is the one that causes the trigger point pain referral.
That's right.
So we're going to take a look at that. And remember, it attaches here onto the condyle of
That's
the
right.
femur.
It is goes above the knee there.
Above the knee, right there. Yeah. So often we want to treat the attachment, and the attachment sort of sticks out a little bit when you stretch it and you contract it. You can see where it's attaching.
Yeah.
Go ahead and push your foot towards me and relax, and push your foot towards me and relax and push. Good. And then I'm going to come. And I'm going to use all my knuckles. I'm going to look for taut bands, and I feel some right there. What do you think?
Oh, yeah.
She says yes, she does have some.
She feels it?
Yeah.
Okay, great.
So how's it feel on your spinal roots there?
It's a little sore.
It's a
You
little
found a
sore?
few tender sore spots?
Yeah, yeah. Ooh-wee.
Good.
So sometimes, so I had them putting a little heat on before I treated her, but sometimes if it was too painful, you might go ahead and put a hot water bottle, nice and warm, a Fomatech hot water bottle, and when you do that, then you come like this,
Yeah.
and it often is much less painful.
Yep.
So it may be not painful at all, because
Yeah.
the heat goes and causes, is a distraction.
Yeah. And
It's
then,
it's an aid in stretching.
and you get less resistance, and then you can treat it more effectively.
And it goes to the brain faster than the pain message at this.
Yeah.
Yeah.
All right, good.
So we're coming along, and here we're coming to the Achilles tendon. And so I'm going to just put it underneath, so we can see what I'm doing. Can you lift your leg up just a little bit? Thanks. So it's nice to put a little bit of heat around a lot of times, and so I often so I've got a few hot water bottles. Mm-hmm.
Yeah, she was stretching gastroc, exactly.
It's too much.
Okay, a little bit too much there. Yeah, here we go. So how's it feel when we stretch it?
She's using her thigh to stretch like that, exactly.
Very tender there.
Very
Okay.
tender there. More on the
Coming
outside,
down?
inside, or both? Both.
Oh, boy.
Okay.
Okay, so we're going to go ahead and we're going to give it a little massage. So it's getting improved in the range of its range of motion. So I'm going to get a little more to the lateral side. So the lateral side's a little tighter.
Okay.
So I'm going to see if I can improve that a little bit more. So you can see when I go this way, the knee side is stretching more. So I'm going to get the lateral side to stretch a little bit more.
And with that stretch, I can feel it in the sacral.
See?
Uh-huh.
How about that?
Well,
Okay.
there is a muscle, and it's not the gastroc, but it's right beneath the gastroc that refers pain right up to where her hand was, right?
It sure does.
Yeah. That's what's underneath. Anybody want to answer it? I won't say it until somebody types the answer. Somebody want to type the answer? What's underneath the gastroc?
Could you
That is
put
one of
the
the
soleus?
furthest away muscles that refers pain right up to the SI joint around L5 there. Anybody have a guess? Yes, Kurt Smith
Okay.
from way down
Look it up
in, I can't remember what city he's in, but he's in Illinois here.
That's right. That's right. That's right.
The soleus, that's right.
Good. The soleus.
Probably one of the furthest away referred pain areas. Very remarkable.
Okay, good. Just bring it over here. Right
Steph,
here.
oh, Steph found a point. See? This soleus. Now, remember, the soleus is like a pancake or like a mattress. It lies underneath the gastrocs. The gastrocs are two big bulbous heads that come down into the Achilles, but the flatter, wider soleus lies underneath and really is close to the bone on both sides, right behind the shin bone on the medial side and right behind the fibula on the outer side, and it goes down flat and then becomes part of the Achilles there.
But you notice the lateral soleus is what causes the pain up here.
That's right. Look at
So
that. A trigger
that's
point
exactly
right there.
where we were.
Yeah, right around there. And it shoots right up. And just on cue, we had the patient say, "Oh, I feel that right up here."
That's
so thanks,
right.
Camille. Right on cue.
How did Camille know?
I felt it.
She felt it.
Camille, you're anatomically correct. Just kidding. Just kidding. Just kidding.
Okay, so to do the lateral head of the gastrocnemius, we're going to go ahead and put a little bit on the stretch on this side, and we're going to go ahead and look for some taut bands. Oh, I found a few right here. I feel some there.
You can see them.
Right here, I feel some right there.
When she puts them on the stretch, they just pop up.
They
You
do.
can just see them
They do.
right.
So this time I'll give them a little massage first. I can feel. Oh, these are tight here.
Oh, yeah.
Okay, give them a little massage first.
And you know, depending on how much you love doing body work, I personally love things to stay fixed. And so when I saw something like that, I immediately went to first metatarsal lift. But you know, you could work on this quite a long while, and it could keep coming back if you don't correct the underlying perpetuating factor. But it's almost like an instant in my brain. Since Sharon trained me, I would immediately think, "Oh, look at that! That's got to be first metatarsal." And what else could cause that? What else could cause a calf to be rock hard like that?
On the outside.
Yeah, on the outside.
Very commonly.
Yeah. What else could do that?
That's one of the common.
It's walking on an ice skate all day. That's what does it.
That's the one. So here we're taking a look here on the outside.
Yeah. You can see Sharon is using straight wrists, straight fingers. The knuckles are bent, and so she's using, and she's probably using a lot of from the shoulder weight. She's not pushing with her arms and forearms.
No,
that's
I used
just
to, for the first 20 years of treating people, I might have gone like this, but for the second 20 years, I'll go like this. And for the following 20 years, I'll go like that again.
The next 20 years, I don't know what she's going to do.
So when I go like this or like that, you know, then I'm stretching the muscles instead of doing this. I'm not shortening those all the time.
If the table is higher, you could use your elbow too, or the side of your forearm.
Yeah, I do different things. So so here, just because we felt the soleus on that side, we'll take a look at the soleus on this side.
Okay. Yeah, you know, what's the difference between getting the soleus versus getting a gastroc, Sharon?
Well, the gastrocs is this that takes up most of the back of the calf, but the soleus is this one that takes up the most. It becomes the ankle right here. So
up here, it's like way under here. It's
yeah,
just
it's
an edge.
underneath.
It's like a narrow edge. Oh, way too deep. Sorry, honey, I was only palpating. Wasn't treating. Oh, okay. So like the shin bone, and then the gastroc, and in between that space, that little groove, that's the side of the soleus, and then it comes out to, you can treat a lot more of it down here. But it's good to get. Sometimes it's too hard to push, and to soften up, you can use cream and do a rotational thing all the way down, just rub it, rotating until it softens up and gets a little warm. They'll say it feels warm to the touch. That sometimes loosens up the soleus really nicely before you go in deeper. But, yeah. This can be an extremely tender part of the area of the body to work, but also very, very delicious.
Okay, that's good. Okay, so we're taking a look at some range of motion here. So down into the soleus, the gastrocnemius, and let's go all the way down to its attachment on the calcaneus, on the ankle, on the heel.
Remember why attachments are so important? Because they've got lots of nerves in them that regulate the tone of the muscle. Remember? Golgi tendon organs, right? We have spindle cells that regulate the tone of the muscle all in the middle, in the belly, and then we have Golgi tendon organs at the musculo-tendon junction, right? So work all those areas. Anywhere where there's nerve affecting the tone of the muscle is very important to check those areas.
So the musculo-tendinous junction would be about here?
Yeah, exactly.
Okay, so let's take a look and see if we improve some of the range of motion.
Great.
Here you can see, let's go ahead and put it at a right angle again. And so we'll take a look. So here, let's put it at a right angle first.
Yeah.
And then let's go and see if we improve the range of motion. So here we go. And then that would be...
certainly improvement.
That would be about 20 degrees, about there. So that was good. Okay, let's look at the other side here. And you can see it also improved. So we're doing pretty good.
Yeah.
So we got some improvement. Go ahead and push your ankle towards me, and then relax. And push your ankle towards me, your foot towards me, I meant, and relax, and your foot towards me. Good. And the other one, and go ahead and push towards me, and relax, and push, and relax, and push. Good. Okay, so let's do the...
See that, Creed?
Oh, good.
Are you is this actually what you're using? Or what's in here? That's not what's in there.
No,
is
it's not.
No.
That's not what's in there.
It's not ultrasound gel.
No, that's not
Someone asked
ultrasound.
what lotion you were using.
Oh, I'll find it. I'll find it.
Okay. All right.
It's I often use Pure Pro lotion. So that's very nice.
Pure Pro?
Pure Pro. That's often
Okay.
use that. Yeah.
Great, great.
Okay, so we did the. So you want to hit the strength test one more time?
Yeah, strength
Okay.
test one more time. Let's see if we had made any difference.
but especially
there.
the lateral head.
Yes, the
okay?
lateral head. So, E to 30 degrees because it crosses both joints, right?
Right.
To test the soleus, we would not.
You're welcome.
We would take this completely out, and we would just be testing this portion of it. But to test the gastroc and that portion, we'll have her flex the foot completely, turn out. I'm sorry, turn
in.
out
In
for the lateral.
Uh-huh.
Yeah, exactly. Okay, keep that out, and now you
Here,
push
look
up
at the
into my
lateral.
hand, and I'm going to add 1, 2, 3. Good.
Oh, strong that time.
Yes, exactly. Even when I let go, and,
Okay.
and you see it grabs even at the end, that was great.
That was good. So we
So
improved
what
that
does
one.
that mean? That means that the entire neurological dysfunction of this muscle was being caused by myofascial trigger points. And
It could
that's
have
what
been when we treated the roots,
Could have been some of that, but
and it could have been
yes.
when we treated the lateral muscle itself. Yeah.
Now, why would that be? Well, if there are trigger points, then wherever there's a trigger point, that portion of the muscle hurts when it contracts. So it won't. So let's say
It may
there's trigger
inhibit it
points.
from contracting.
Exactly. Let's say there's trigger points through 30% of the muscle, then 30% of that muscle doesn't want to contract. So contract, turn this, turn. Sorry, yeah, out like
Yep,
that.
that's good.
Good. Push up into my hand, and then I'm going to add 1, 2, 3. Good.
Wow.
We
that's
fixed
strong.
that.
That's- Okay.
Congratulations.
Hey, great. Okay, super.
She can be fixed.
Okay, so go ahead. Yeah. Okay, so let's go. Oh, and by the way, here in Chevelle's book, she's showing here how to make a first metatarsal lift at home. This is before the first. Oh,
This is before the sexy but not painful slips.
So here you put it right under the metatarsal head. So they just took a insert, they cut the toes out, and they put like mole's skin there, and then they put that to make the tripod and to lift the first metatarsal.
There you go.
Yeah.
Yep.
Okay, the second muscle we're going to work on today
Second
is
on the list,
yes, the second is the gluteus medius.
or minimus.
Minimus, I'm going to say
Why
gluteus
would
minimus, because the minimus
What
is
does
the
the
one that
minimus
goes
have
down the
anything-
leg.
Oh, that's the pseudo-sciatica muscle.
Okay, we're going to have you go ahead and sit up, and then you're going to have you stand up, and I'm going to help you get off.
So the sciatic nerve.
Help me get up.
Uh-huh.
The sciatic nerve runs all
So
the way
this is
back
what
down.
we call pseudo-sciatica. Okay?
Yeah, it runs.
Could
Yeah.
you pull the gluteus minimus out? Okay, so here is the gluteus minimus somewhere around here. Where it is? Okay, there. Okay, so here, I don't know where it is on here. Okay, Stephanie, can you show it to us?
Here it is. Sorry.
Oh, there it is. Okay.
That is
So
nice.
here, gluteus minimus. We're looking at the front part of it here, and this goes all the way down, and then it causes pain on the outside of the lateral leg there. So the outside of the lateral leg, and so this is the trigger points here, right near the TFL. So right near the front part of the hip. So we're going to do a couple tests for that, okay? And then we'll take a look at that muscle.
Yep.
Yeah.
And the sciatic nerve, runs right through that same area, all the way down to the heel, and that's why people get confused and think they're having sciatic pain, because it's the exact same region. But the sciatic nerve, if it's true sciatica, will be more of a shooting electrical pain, and this will be more of that achy referred pain. So,
So here it is, and so it's going to be attaching onto the pelvis and then onto the greater trochanter.
yeah.
And that's be L4 and S1. And then we're going to do test 45 and 51.
So the glutes really come in a 3-pack, don't they? They've got the little minimus, which is toward the front and
Yeah.
down, and then
Yeah.
there's the medius that's like a fan
Over it, yeah.
And then there's a
The
big
gluteus
fat
maximus.
gluteus max sitting toward the back of it.
Yeah, that's all of our gluteal muscles there.
All right.
Okay, so we're going to look at test 45 and 51. So let's go ahead and look at 51. This is the leg cross test.
This is my favorite one for that. Yep.
And then the next one, 45 here, is the Bonnet sign.
Yeah.
So this would be 45 here. So, and then 51. another one that would show it would be this one as well, the hip flexor test 31. So that this one could show us. Okay.
I really like the 51 the best because
All right,
it's
let's
good
do
at
the
showing the
51.
patient.
Okay.
It's good at showing
Okay,
the patient. They
so-
can see.
So can we take a look at yours?
Yeah.
Okay.
All right.
Okay, let's go ahead and sit right here, and let's have you go ahead and cross your legs. So, how's that feel?
Fine.
Does it hurt?
No.
Good. Then, not that. So often if you choose that way,
That's right.
yeah, then you're not stretching that muscle. So then
Okay.
often, so go ahead and show us that one again. So this would be a lot of times if you can't stretch the muscle, you cross your leg that way.
Yeah.
Oh,
So
So
this
this
is
would
the
be a-
same muscle from like
Yeah.
several weeks ago.
Yeah.
Okay, so
yeah.
but let's cross it all the way over like this and look at you. So you have only perfect with just like barely a finger getting in through here. Let's
That's
try
it.
the other side.
So when you cross the leg
Mhm,
over the other, there should be no space in between the
Yeah.
two thighs.
Yeah, yeah. So no space there.
How about
So-
you?
I got space.
She's got a
So
little space.
so versus
So
versus
here,
she can
so here's,
fit
so there's like two
two.
fingers.
I can almost get 3 of my fingers.
Two fingers, and then
Okay.
the other side. Oh, so see how everyone measures different. Okay, I would go 2
Yeah,
fingers.
2 fingers on that side.
I
for
got
sure.
space.
All right.
I passed something.
You passed something.
Something.
Well, then should we use Camille then to work
No,
on that?
I was gonna do her.
Okay,
her
even though
legs.
it's
Couldn't
even though
do it.
tests okay.
No, she passes.
Oh well, I figure I'll probably find some top.
Well,
Well,
you'll
that's
find
good. That's
something.
good. That's good. All right. Absolutely. Absolutely.
Okay, so
Okay.
let's come over here. Let's take a look at you. Is it easy to turn your toes in? This is another good test. Can you turn your toes all the way in? How's that feel when you turn your toes in?
Okay.
Good.
Why is that a good test again?
Because the gluteus minimus turns your toes out.
Yeah.
So the gluteus
Or
medius.
well,
So this is everybody feel their butt here.
Uh-huh.
And when you turn your toes in, you can feel this stretching here.
yeah.
And then when you turn them out, you can feel them contracting. So
Yes,
so
contract.
but a good so
Gotcha.
so what you want to do is turn them in for a good stretch.
Okay.
Okay.
Good. Perfect.
Okay, so we're
Nice.
going to treat it a little bit while we're stretching it. Okay. So we're going to take a look at it on the stretch, and so that's kind of fun. Oh, and we did. Let's look at your
Your
spinal roots a little
Yeah.
bit there too as well.
Okay.
Okay, so let's have you step up on here and come up here. So we looked at them standing. Now we're going to have you do it laying down. Stephanie, could I have my treatment jacket? Okay, so let's take a look at you laying down. Oh, the skin is rolling here. Skin rolling. Oh, it's getting a little tight here. But it's good. No, it's very good. Look at this. Look at the S's. The S's are beautiful. Okay, the L's.
Oh yeah. Very
The
nice.
L4, L5.
Really
It's supposed to get a
nice.
little tight coming up, but it's pretty good. So I'm not going to be worried about that. You're excellent. So your self-care probably fixed that, or in addition.
Well, we fixed the hip issue
Yeah.
a couple weeks ago too, and that probably helped a
that
lot.
probably
So.
helped too.
Yeah.
Okay, thank you. Okay, official right now, Stephanie.
Oh no, no. Now she's woman versus pain.
I gotta have to have that. Okay, okay. So we're gonna take a look at the gluteus minimus. So here we're gonna take a look at the greater trochanter, right
Okay.
here. So this is the attachment on the greater trochanter, and we're gonna go and take a look at and look for some taut bands in here.
By the way, it was L4 thrust 1, guys, that she was looking at for the nerve root.
Okay, so I feel a few taut bands here in the anterior section.
So show us where you would be palpating the glute max and then medius and then minimus.
So here, so the medius would be up here. So you're
That
looking
fan shape?
so you'd be looking for the medius trigger points up here. So so that you'd be looking for taut bands here up higher, and when you're going to treat them, you're going to go towards the iliac crest like that.
Gotcha.
Okay, and for the minimus, you're going to find the greater trochanter, and you're going to look for trigger points and go towards the greater trochanter like this. So that would be for your gluteus minimus.
Okay.
And for the ones that are going to go down the side of the leg, you're going to look over here, and I can feel some right here. So you can see she has some taut bands right here.
In what direction do you push there?
So I'm going to press straight in.
Straight in?
Yeah, I'm going to press straight in. But I'm also going to do something on the stretch for her.
And then the gluteus max you would do.
Yeah, the gluteus max is going to be coming and attaching here onto the sacrum a little bit, and it's coming this way across everything.
Gotcha.
Okay, and attaching over here.
Yeah, make sure you don't forget that it gets all the way back there. Exactly.
Comes all the way over here. Yeah, and then it attaches there.
Great.
So that's our gluteus max.
Right.
Okay, so we're going to take a look at here in this position, and then we're going to look at this one. We'll do this one on the stretch.
Super.
Okay, so here we're going to find the greater trochanter, go superior just a little bit, and we're going to press in. And first we're just going to touch, and then we're going to feel a little bit of the resistance. And how's that feel when we can feel a little bit of resistance there?
It's a little tight, yeah.
A little tight, you feel? And we're going to go push towards the greater trochanter, towards the outside hip bone right here. So towards your hip bone.
Okay. So you're pushing down and out, sort of?
Well, in this case, down and inward.
Down.
So because the muscle is kind of like a fan shaped like this, and we're kind of going down, finding the muscle and pushing it towards the greater trochanter.
I would call that out. But...
Yeah, down and out.
2 versus 1, Sharon. Who's the master worker now?
Okay, now here I've got some taut bands here. Can you feel that?
Yeah.
Okay, so now we're going to go and press in and towards the greater trochanter.
If they're not tender, is it still sometimes important to treat a taut band?
Especially if it's taut, if it's painful, and if it's taut, both you might want to treat. Yeah.
Yeah. Okay.
Yeah. And then we're going to go a little bit more anterior. I got my elbow right on it, and then go again down towards the greater.
Yeah. Some would suggest lateral and inferior. Yeah, that's probably good.
Yeah.
We're technically correct now.
You got to be technically correct.
Yeah, lateral and inferior.
Lateral and inferior.
So now you're pretty much going inferior and just straight inferior? Or?
Yeah, so I'm coming in and inferior. So
Gotcha.
here we're going lateral. Here we're going lateral, more inferior. Here we're going more inferior, and here we're going mostly inferior.
Gotcha.
Yeah. So so we're coming down this way. Yeah. Okay, so let's take a look at we'll give it a little stretch, and I'm gonna go ahead and give it a little stretch over here.
Now I'll show you the test afterward. There's not. It's okay. It's okay. I don't think she's. I already know she's not going to test weak. I can see by everything she's. This muscle seems to be functioning really well.
Okay, so I'm just giving it a good stretch.
Yeah.
Okay, go ahead and press your leg towards the windows and relax. And that's good. And give it towards the windows. Good. Okay, great. So we gave it a little stretch and a little contraction.
Yeah, and we'll do self-care in just a minute, guys.
Yeah.
Yep.
Okay,
good
so
question.
if I could have this hip, and I'm going to have you come up on your hand. Actually, just stand up, and then I'm going to show you what to do. Yeah, good. Perfect. I'm going to assist you here. Good. Okay, next I'm going to have you come this way for the right hip, and you're going to come like this. You're going to hold this one down, and you're going to put your head. I'll put a pillow for your head, and you're going to push your leg down like this. Okay.
All right, here's a super duper master body worker position for treating the glute medius on the stretch.
Okay, so here's a little pillow for your head.
So this is
I'm a little dyslexic, so is this on the top or the bottom?
Yeah, that's it.
Okay.
So we've got the body
All right.
support. Now this is the top half separated from the lower half so she can slip in between.
Oh, okay.
Yeah, there you go. See?
You're relatively comfortable?
Wow.
The ball may be a little
Okay,
bit
so-
much. Maybe a cervical roll, but yeah.
Do you want to give me a pillow from underneath there? Okay, so here you can feel there's a little bit of tension right here. Yeah, you can feel, yes. So this would be, so here we're going to go look for so here's the anterior portion of it. I can feel taut bands right here. I can feel a few here. So the part that would cause pain in the lateral leg is very taut. Right there.
Okay, all right.
So I'm going to go ahead and press on it. How's the pillow?
Okay.
Good.
Okay, you guys see this positioning? Her shoulders relaxing comfortably in between the two parts of the body support system. Pillow to give her keep her neck straight. Then the bottom leg is crossed over the opposite calf and is getting a really good stretch on the upside leg. And that is where we're going to see the trigger points that might be hard to feel otherwise come right to the surface.
So right here, yeah. So did you have any lateral leg pain?
Yes. But I always thought it was from
the Morton's foot thing, which we're trying
Yes.
to correct, but I've had it for, I don't know, 50 years. Kind of would take
50?
a long time to
50
you know,
years.
make it go away.
Might
That's
take
a couple of years.
Yeah. So I still have some residual
Mhm.
tightness
Mhm.
from that.
Yeah.
Well,
Um,
50 years of feeling it, it's used to being that way, so it'll take a little time to get used to being
It
a
may.
different way. Yeah,
It may.
it may, but you know, even if you correct the first metatarsal lift, which is beautiful, the muscles may have to be gone through each one, you know, because they have their own memory. And
Okay, so it's feeling much better. How does it feel to you?
It does
It's
feel
coming
like
way
it's
down.
relaxing.
It's not holding itself
Yeah.
up anymore.
Mhm.
Okay, I'm just gonna move it a little bit. Just see how it feels when I'm moving it. So, you've been doing. Sometimes tell us what profession you've been doing recently.
Well,
kickboxing.
Sitting.
I was a financial advisor, so I sat in a chair for
Uh-huh.
8 to 10 hours a day
For
33 years.
I was gonna say 30.
You didn't hang upside down from a trapeze?
No, that actually might have been good.
Yeah, you could give financial advice that way.
Yeah.
You know, people forget that you do something odd, then everyone knows you. You know, you can grow your business that way.
Okay, let's have you go ahead and stand up.
You could have a tagline like "Tired of your finances swinging back and forth."
Okay, and let's have you go ahead and
Need
sit
a
down.
lift?
We'll do
I
the
need a
test.
lift.
Do the test again. You do the test.
You need a financial acrobat.
Okay, go ahead and cross your legs.
Well, it was good
And-
before.
And it was good before. How's it feel now?
That's good before.
And then cross the other leg. Okay, and then how's your pain?
No pain here, just a little sore here.
Okay. Okay.
Digging.
Good for my elbow. So
digging in
put a little heat on that. So go ahead after turn one of them on and put it on that little area there. Good.
Should we see the?
Oh.
Should we see a strength test on it?
Oh yes, we're gonna do the strength test first.
Okay,
Okay.
the strength
So
Okay.
let's go ahead. Let's do that. Hang on for a
Line,
second.
Face up on your back would be best.
Okay, go ahead and lay on your back.
And so I'll give the overview on testing hip abduction tests, okay? I always get confused between ab and adduction, but add is getting two numbers together, so that's how I remember. Adduction means bringing legs together, so we're adding. That's why that's adduction. And abduction means pushing away. Okay, so there are three angles to do an abduction test, and the one is with the hip up at 30 degrees and turning in. Hold that right there. I'm going to move at this exact angle. The TFL muscle is now straight, and so this is the test for the tensor fascia lata, which is the little muscle that goes from here right to here and grabs onto that huge iliotibial band. Okay, so push up and out into my hand. She pushes. I add 1, 2, 3.
That's
Oh,
really
that one.
sore.
So the TFL is a big problem. That's not the one we're doing
what-
in this class.
Yeah, well, we
Well,
didn't
I
teach-
want them to feel the difference.
Oh, okay.
See the difference
Okay.
between, okay, and then straight to the side would be glute medius.
Okay.
Okay. So push straight out into my hand. Push that way, and I'm going to add 1, 2, 3. Also weak, and then glute minimus. I'm going to bring her leg down at 15 to 20. Have her leg turn out and push down at an angle and out. So this way, push down and out
Oh, I
into my
see
hand.
all of them. It gave us all
Push
of
down
them.
and out, 1, and then I'm that's the worst of them all. So the variations, I would say, you know, the TFL and the glute medius and the minimus all tested weak, but remember they work together. The weakest of them all was actually the glute minimus. Okay, let's try
Okay, let's try the other side.
Okay, just like I just wanted you to see the difference with the glute max,
Yeah,
glute medius,
all
glute
of them.
minimus. So here, when you're doing abduction, remember, abducting toward this direction is the TFL. So turn the foot in and push up and out. And I'm going to add 1, 2, 3. Doesn't like that too much, but I would give that like a 2 out of 5. Then straight out is glute medius. Push out, straight out, 1, 2, 3. No, and I'd give that maybe a 1.5 out of 5. And then down 15 to 20 degrees with the foot turned out now, that direction, push down and out into my hand, and it's like there's nothing there. I mean, I don't, as she pushes, it's almost like I can't do it. I give that a 1 or less.
Okay, so we're going to need a little bit more treatment on those muscles.
So for sure, those are not firing right.
Yeah.
Yeah.
And so we continue to work on those.
Yeah.
Okay, good.
Yeah.
Okay, so why don't you go ahead and turn to the side and go ahead and sit up. Great. Okay, and then stand up.
And I was surprised. I actually thought they were going to test well.
Oh.
Yeah, I really did. So
Okay.
their range of motion test was pretty good. The palpation, what would you have given it? Palpation gave a lot. Would you say it was
there were some taut bands.
some type bands?
But again, I wouldn't have thought it would have been so as weak.
Yeah.
But
And
then-
the neurology
Yeah,
was
yeah.
quite a bit. So
Yeah.
it could be another muscle
Yeah.
that's causing a neurological reaction in that muscle. So
Yeah, so we're going to take a look now at the peroneus, longus, and brevis and tertius. So let's take a look at them. So this is the muscles we're going to take a look at, and you can see that here's our peroneus longus, and it attaches onto the fibula head. So everybody, let's see if they can find their fibula head.
Okay.
So right here, that's your fibula head. So you can feel that on yourself.
down the knee, and then there it is, that hard
You
bony.
feel that bony part there.
Yeah.
So it attaches right there. Then it comes down, and attaches over here onto the fibula, and then down around the ankle bone, then over to the metatarsal head, and then over here into the inside of the.
So it wraps around the outside of the foot. Let's see.
Yeah. So first it comes here, the fifth metatarsal head. So it starts here at the fibula, then head, then comes down the fibula, then back through here, behind, and then over here to the and comes underneath. So this is the peroneus brevis, and that attaches right on the fifth metatarsal head, but the peroneus longus is a little bit posterior to that. And then it comes across and attaches onto the medial cuneiform and the first metatarsal over here.
That's really important. So you guys see that? So the longus goes all the way, wraps around, and grabs onto the big toe.
Right.
The base of the first metatarsal.
Right.
The little tertius starts right here. It only grabs onto the bottom, right about there. There's a groove where you can feel it, and it comes and grabs on
And it goes
here.
in front of the ankle bone.
Yeah.
And the malleolus, and then it also attaches here at the fifth metatarsal head.
And then the brevis goes behind like the longus, but it attaches, it stops. It doesn't, the tertius and the brevis both go to the fifth metatarsal head, but the longus slips on through and attaches all the way to the underside of the first metatarsal.
And it has nerve roots L5 to S1. And we're going to do 44, the range of motion test for that, and that's to be able to turn your ankle inward like this, or eversion like that. So that would be
Eversion.
eversion.
Or,
So
no, that's inversion.
I meant, this is, okay, I'm
Yeah.
sorry. Inversion. Eversion is its contraction,
Yeah.
and inversion is its range of motion test.
Yeah,
So
inversion
here's
is a range of motion
inversion.
test, exactly.
Yeah, inversion is our range of motion test,
Exactly.
and eversion is our strength test here.
That's right, exactly.
So that's our peroneus muscles here.
And I think we might
Okay.
find something really neat with this. Can we use her again for that muscle?
Oh, we're gonna look at your. Do you want to look at your peroneals? Okay.
Sure.
So let's have her test. Let's test your. Let's see if how good you do with your
Oh,
inversion.
should we take a break?
Oh! We're supposed to take a break.
All right,
Okay,
so we're
let's
gonna,
take a break.
we're going to take a break. When we come back, we're going to get to the peronei. So we will, it is